Let's see here. Good.
Great, you're starting it up over again.
Yes.
I'm talking to you through Zoom.
Okay, I'm going to invite you. Okay, hello everybody. We are doing an Instagram Live, kind of an impromptu Instagram Live. I'm just going to wait for my guests to get here. I have Dr. David Rosensweet and I have Dr. Holly Papanek. Just waiting.
I saw the invite pop up and then disappear. You may have to resend it to me.
Okay, I'm going to just resend that. Let's see here. Okay. Okay, let's see if we've got. Hi guys, thanks for joining. I see a couple of you guys are here. We are going to talk about Bi-Est, and I'll explain why in just a minute. I'm getting a lot of questions about Bi-Est, so I wanted to bring in the experts on Bi-Est to explain why so many of us in the menopause space are fans of Bi-Est. There's Dr. Holly Papanek. Hi, Holly.
Hello. Hello.
Let's see, we've got Dr. Rosensweet. Let me make sure he can get in here. Let's see. I know sometimes this is the trick. It's like getting everything lined up. Let's see. Here he is. I'm going to invite him again. Let's see if this works. We'll have all three of us here. Okay, I think he's here. We're here. We did it. Hi, Dr. Rosensweet.
Hi, Jill.
Hi, Holly. Sarah. I see a lot of people are joining already. So I want to just explain, for whatever reason, I'm getting a flurry of questions about Bi-Est, which is a type of hormone replacement therapy that contains two different types of estrogen, estradiol and estradiol. Lots of questions coming in. And so I thought I would bring in the experts, Dr. David Rosensweet, who you guys know from our community if you're in the community, but you've heard about him. He's been practicing menopause medicine for 30 years, I think, at least. You've been a physician for 50 years, so it's been a long time. And then Dr. Holly Papanek is here. She's part of our Institute of Bioidentical Medicine family, IOBIM family. We are all meeting weekly for grand rounds. We've gone through training together. Dr. Rosensweet has been our mentor and our trainer. And we want to talk about Bi-Est. What is it? What's the big to-do? We're getting tons of questions because people are really confused on why we would choose Bi-Est versus something like estradiol alone. And we thought maybe you could answer that for us.
Yes, be happy to.
Okay.
And I first got interested in treating women in menopause in 1992, and I dived into what little was known and being talked about then. And one of the first things I encountered in talking about estrogens was Bi-Est, and it was formulated by a pioneer in this work, Dr. Jonathan Wright. And really, I think his approach to this originated from wanting to replicate nature and not invent a new woman. But really, he based his original ideas around the medical literature, because in the late 1960s, Henry Lemon, a medical doctor at the University of Nebraska and an oncologist, did a study examining the urine of young, healthy women regularly menstruating, and also women who had breast cancer. And he found a difference in the hormonal patterns. He found that the young, healthy women had a prevalence of estradiol. In fact, they had 1.3 times on the average more estradiol than they did the sum of estrone and estradiol, the two most potent estrogens. Whereas the women who had breast cancer had less, remarkably less, statistically significant less amount of estradiol as compared to estrone and estradiol. So Dr. Wright took this as, this is how it appears naturally. Why don't we respect this and do this? Bi-Est was born. And when I started out with Bi-Est. Loved it, had great results with it. Interestingly enough, in the 1990s, two estrogen receptor sites were identified. Nobody knew about them before. Dr. Lemon didn't know about them. They're estrogen receptor site alpha and estrogen receptor site beta. And they're very active in a young woman's menstrual cycle. Estrogen receptor site alpha inspires proliferation. the very first phase, the weeks of a cycle. The uterine lining proliferates, new cells are formed in anticipation of a possible implantation of fertilized ovum. The breast preparing for lactation right there, each menstrual cycle. New cells are formed through cell division. Women often feel this. They often feel a fullness develop over the course of their month. And if there is no implantation, a whole deproliferation phase of the cycle occurs every single month. And that's under the auspices, the inspiration of estrogen receptor site beta. Now, the prime stimulant of estrogen receptor site alpha, the proliferative phase, is estradiol, the most potent estrogen coming out of the ovaries. And the primary stimulant of ER beta, the inspiration for deproliferation, is estriol. This occurred in the 1990s. So, interestingly enough, as an aside, in the early 2000s, I was invited to assist a major American laboratory in developing hormone testing. And I asked them if I could do a study trying to develop reference ranges on young, healthy women. And we chose nursing students, 20 to 29. And we interviewed and did some examinations on 600 young nursing students. Only 100 of them were regularly menstruating, which was a criteria for doing the collection. And they all had normal BMIs. They were all gravid 0 and regularly menstruating. And we collected those samples. And here's what we found in the early 2000s. Estriol was more prevalent in these young, healthy women than the sum of estradiol and estrone. Instead of 1.3 on the average, we got 1.1. It's just an aside, but it was a confirmation that what happens to be normal for young, healthy women happens to be, Dr. Lemon was spot on, same technology, so no big surprise. Now, one of the risk factors for breast cancer, and there's not a lot of specifically known risk factors, but one of them is increased breast density. In other words, increased proliferation of breast glandular cells. So the bottom line in treating women in menopause is do our very best to prevent breast cancer. Bottom line. Thus, prevent proliferation. So am I a fan of the deproliferative estriol? Yes, there's a lot of moving parts to the developed creation of cancer. I'm not, and hormones aren't part of them. But why not conform to nature and deproliferation as part of what can be healthy for a woman? And that's why we choose Bi-Est. Now, it turns out, I also viewed this recent comment about Bi-Est, and I was a little concerned because there was a claim.
Oh, I think we're freezing up for a minute. Do you guys see that? Let's see. Hold on. Let's see. Let's make sure this. Holly, is it freezing up over? You look like you're still.
Yeah.
Yeah.
I think I'm fine. I can see that he's frozen though.
Okay.
He's spinning.
Yeah. Let me see if he comes out of that because this is a really important point I think that he's going to make. Let's see. He may have to just, let's see. Yeah, I know thanks guys. I know he's frozen. We're going to see if we can get him. I may have him log out and log back in. Let me see if I can, let's see.
The joys of live podcast, huh?
Let me just tell him. I'm going to see if I can get him. I'm going to just text him to see if he can.
I talked to you through Zoom.
Yeah, I'm going to see if I can log back in. I'll try to re-invite him. Oh, I thought I.
Can you hear me, Jill? I can hear
back.
you.
You're back. Okay,
good.
I was just texting you to say we
But
lost you. So you were just at a very critical point where we were talking about deproliferation. Just a risk factor of breast cancer is that that women have denser breasts. That's kind of where it left off. Yeah.
I'm back. Yeah. And did you pick up the part upon the risk factor for breast cancer? copy nature and deproliferate, emphasize deproliferation. We don't want to see proliferation, and I've learned this from a gynecologist actually, who wrote an article in an OB-GYN journal saying mitosis in a midlife woman is not an exciting thing, and don't be trying to stimulate proliferation of breast glandular tissue in mitosis. It's a vulnerable part where mutations can occur. So really, you can see why I might be such a fan of something that's nature's way of deproliferating and thus Bi-Est. Yeah, and you know, this was so important then that when I was called to testify in front of the National Academy of Science, Engineering, and Medicine for their ad hoc committee on the safety and efficacy of compounded bioidentical hormones, I had several subjects that they wanted me to present to them, and this was one of them. And I did this, and I documented this. And in fact, Jill, I'm going to supply to you at least the titles so that people will easily be able to look up the literature. The full citations are in our book, which people can download. But this is an important subject in the bottom line. The other thing I wanted to address is there were aspersions about compounding pharmacists and physicians in this recent Instagram video that I saw. And I did want to give another point of view, that I've been deeply immersed in this field for 30 years and have met just hundreds and hundreds and hundreds of professional colleagues, even to the point where the CEO of the Alliance for Compounding Pharmacies in the United States and I are co-chair a committee, coalition to protect compounded bioidentical hormones. There's 7,500 compounding pharmacists. These are some of the most diligent, compliant, scientific, caring healthcare providers that I've ever met. I have great honor for them. I have great respect for them. And I know so many physicians, since this is what I've cared most about over so many years, and nurse practitioners and PAs, wonderful people who are devoted to specializing in this work. And they so often choose Bi-Est because of the science behind it. I'm not diminishing other people's approach unless I don't think it's good science, but I would like to put in a very strong, heartfelt caring for these devoted men and women who care so much about their patients as much as we do, and are doing excellent work with excellent technology and preparing these individualized based prescriptions that we can actually do for individual women and individual men, because there's tremendous variation woman to woman is what her ideal balance is. So thanks for letting me say all this subject that I care so much about.
Well, and you've been prescribing Bi-Est for 30 plus years. I've joined of late as well too, and I just get such great results specifically to those ratios that you speak of, dating all the way back to the research by Dr. Henry Lemon and Dr. Jonathan Wright. I mean, there's some nice robust data that supports this, and our goal is to have women individualized in their treatment and healthy with a healthy breast as well. So
can I just ask you too, this was great, and we're going to include the studies on estradiol that you have and that you presented to the National Academy of Science and Engineering, right? From it, I guess what I'm wondering is if people aren't testing, because I think there's this assumption that if you give a woman estradiol, the woman will automatically sort of convert estradiol to the estrogens in the right ratios in the body. And you would only know that, so those levels you're talking, or the ratios that you saw in younger women, you would only know that if you're doing true 24-hour urine hormone testing, right? So, but what you found, I guess part of where your love of using Bi-Est came from, I think from what we've talked about, is you've tested women for 30, or as long as you've been able to test women using 24-hour urine. And when you gave estradiol alone, you didn't necessarily see those ratios play out that way, which is why you found that rationale, the importance for actually adding estradiol to the mix to make sure you had that balance. Or maybe you can speak to that. You probably can say it more eloquently than I can. I think we're spinning again, just for a minute. Hold on. We're spinning a little bit. Let me see if I can get him. It's just, oh, there he is.
Oh,
Okay.
he's there.
Yeah. Okay. Did you hear what I said, Dr. Rosensweet, or no? I just
Yeah,
wanted to be,
I'm all ready
okay,
to go.
perfect. Yeah.
I love that you asked this question, Jill. I mean, the main reason why I'm here today is that 30 years ago, I simultaneously started testing every single woman, what was the gold standard of hormone testing in a woman you're treating, which is 24-hour urine hormone collection. And I got to view what was going on in a woman when we were treating her. And I even went through a phase of trying pure estradiol. It was a very short phase because, as you suggested there, I could not replicate a prevalence of estradiol in the same testing methods that Dr. Lemon did in the late 1960s. Many publications he did on this subject. And what I thought was best to do was to work with a prescription that could in some way come close to the prominence of estradiol. And so we've monitored thousands of women by 24-hour urine hormone tests. And one of our goals in the method that we use is to replicate a prevalence of estradiol, not a domination by estradiol, but a prevalence of estradiol that copies nature. Thus, a prevalence of estradiol that inspires deproliferation and balances any proliferative aspects of a wonderful hormone called estradiol.
Mm-hmm.
We're not here to diminish the importance of estradiol. We're here to balance and offset its proliferative effect with estradiol. Thank you. Those 24-hour urine hormone test results over 30 years, we're always aiming to replicate, and with compounding, with being able to individualize the ratios of the original Bi-Est prescription, we can replicate what nature does.
Yes.
With women.
Yeah. No, this was really helpful. I just had seen one comment I was just going to share. Yeah, just saying that there are a lot of places that are recommending Bi-Est, and then there's some that are almost like very anti-Bi-Est, and women just saying it gets really confusing. And so maybe we can even go back to what we've talked about many times at IOBIM is like any estrogen is going to be beneficial for the body. So I think we're trying to offer, there's this buffet of options, but you've always talked about just you want to practice best medicine, and this from your experience has been really, falls into best medicine and best practices. So it's not like you said to diminish estradiol. We love estradiol. It's just to really make sure those signals are balanced, but we can see why women are confused.
Yeah, it's a very unusual field. There is no board certified specialization, although our group is definitely working towards this. There is no standard of care. It's sort of the Wild West. And you have very few specialists in this. There is a lot of confusion out there. This is unlike other specialties. In urology and neurology, there's a core body of knowledge. They might have discussions at the periphery, but not like in this field.
Yeah.
I just want to give you my best shot. And I do like that you say, women who are treated with hormones in menopause benefit, they know it, their doctors know it, and it lessens the risk that they have for breast cancer, heart attack, and stroke. We're all at risk. As a male, I'm at special risk for prostate cancer. But women who are treated with hormones, men who are treated with testosterone, our risk for breast cancer, heart attack, stroke, prostate cancer is reduced. And there's been a lot of hormone treatment over the last 50 years for sure. And, most everyone has benefited from it. Yet, we also, like neurology, like urology, 30 years ago is different than what it is today. We've learned so much from the patients and from the testing and from the medical studies that I'm going to lean towards best practices, best knowledge.
Yeah. And let's keep in mind too that Bi-Est is estradiol and estradiol. That's why it's bi. I mean, it's the two components there. So you're really getting the best of both worlds. And in fact, Dr. Rosensweet has it titrated down so much that there's different components of each, 80-20, 70-30, and it's very individualized according to the 24-hour urine. He can dial it right into exactly what each woman needs depending on those ratios. So it's pretty intricate and very elegant.
Yeah, I appreciate that. I mean, this was great. I really appreciate you just kind of addressing a topic that has always been sort of a hot button topic, I think, for a reason that I don't know. I think we just want women to have the best care. And I think these are the hormones made in our body. So, no need to any hormones, right? I mean, the hormones that are made in our body are just super, super important. So we appreciate you being here. Thank you for shedding some light on this. This will be saved and we will post this so that women can have access to this. Share this with your provider. We'll share the studies. You're going to send me the studies that you have and we'll share those in the comments. So thank you everyone for coming.
Thank you, Jill.
All
Thank you,
right.
Holly.
Yeah.
Okay. All right. Bye guys.
Bye-bye.